what single biggest misconception that leaders still have about rural healthcare transformation?
They all think that the rural poor have to be saved. But in reality, the poor, the rural masses, I won't even say the poor, they already have the solutions. They have the resilience. They have the network. And what is it that they lack? Resources, recognition, and systemic support.
What did that conversation teach you about healthcare that destroys families that nobody else was paying attention to?
She said, I will buy, but I will pay what I can afford. And the second thing is, if you promise me, if I have given you 50 rupees, that you'll keep your promise and give me what you have promised in terms of healthcare. I don't want your charity. I'm not a beggar. I want to be treated with dignity and respect.
Welcome to the Spark and the Forge podcast. I am Subrata Kar, and this is where we unpack the boldest shift in tech, systems, and outcomes with data that matters. Here is what I don't get about India's rural healthcare. India's eSanjeevani teleconsultations platform processes about 344 million consultations, but only 20% result in useful prescriptions. Meanwhile, 8,000 rural women, most semi-literate, achieve 94% health behavior adoption across 6.25 million people. So either we are completely wrong about our healthcare delivery, or we are missing what actually drives change in rural communities. My guest today cracked this puzzle 25 years ago. Mukti Bosco, 2022 Roux Prize winner, first social entrepreneur, and first Indian to receive the world's largest public health award. Ashoka Fellow since 2007, part of the world's largest network of social entrepreneurs. Here is her breakthrough insight. You can't fix health without fixing economics. Getting sick bankrupts families. The poverty health cycle keeps spinning. Mukti's community health entrepreneur model breaks both problems at once: health access and economic empowerment through the same intervention, achieving nearly 5 times better outcomes than government platforms. So if you are building social enterprises or trying to figure out why rural innovations keep failing, then this conversation will challenge everything that you think know about scale, technology, and what actually works. Following is my conversation with Mukti Bosco. Before we dive deep, explain what a community health entrepreneur is and how different they are from accredited social health activists.
The community health entrepreneur are women from the community who go through a training in preventative health education and also to support the Asha workers or the Anganwadi workers and the health systems at the community level. She's embedded in the community and there's a lot of trust that is built up. And she goes through an intensive training program where she learns health systems, she learns about health communication, common illnesses, milestones from the womb to tomb, and also learns first aid in the first year. And in the second year, she learns how to do vitals, and she also learns how to connect the community member to telehealth doctor. She also learns how to be an entrepreneur in the village by selling some of the products, health-based products and services. The most important thing of the CHE is she is a trusted resource in the community. She leads change by changing herself, her behaviors in health, her health-seeking behaviors, and the community and her family behaviors. So she becomes a go-to person for any kind of health crisis in her village, in her community. She leads as an example in the community, and that is what differentiates. The community looks at her as one among them, but with health skills, and that is the biggest differentiator. The trust and the behavior change that she brings about in herself and in her family, and leads by example.
25 years ago, you were doing field work near Charminar. Woman tells you that she pulled her 6-year-old out of school to work at a tea shop, all because of 5,000 medical debt. What did that conversation teach you?
I asked them, what do you do during a healthcare crisis? The women said, oh, we pawn or mortgage our productive assets. A productive asset was a milch cow or a goat. And then one of the women, she nudged the other lady. She said, my 6-year-old child, I had to pull him out of school and put him in bonded labor to just get a 5,000 rupees, which at that point in time was equivalent to about, say, less than $10. And to pay for a treatment that took my soul, because my son was just 5, my daughter was 2.5. And I said, well, I mean, this is not on. I live in Hyderabad, and another child who's 6-year-old has had to work for almost 10 to 12 hours a day, and he misses his education. And that pushed me towards starting Healing Fields Foundation. At that point in time, I thought that healthcare financing could potentially be an answer to this intergenerational poverty, and support these women and their families by helping them.
Seems to me the real problem isn't just lack of doctors or clinics. Getting sick bankrupts families, which keeps them sick forever.
It
Even after
is
27 years, we're talking about telehealth platform, which is our eSanjeevani, has got 344 million consultations, but only 20% result in useful prescriptions. Private companies build apps assuming that people have smartphones. Why does everyone miss this poverty to health cycle?
one of the major things, Subrata, is all developed from a top down approach, not from community upwards. The community and the poor have no stake in developing anything. It is the knowledge and it is their lived experiences. Many of the telehealth apps that are available not seen their lived experiences, and it is still a reality. I just came back from Banda in Bundelkhand, and it just again shook me up. And this particular town, there is no private hospitals because the people are so poor, they can't afford to pay for private care. And the government hospital is doing some great work there, the primary health center, the community health center, about 500 outpatients, but they are stretched thin. eSanjeevani, of course, is there, but does not meet the needs of the poor.
So most healthcare interventions, seems to me that they attack the symptoms while ignoring the root cause. But what you have identified is something unique. You connected the economics and the health together. How did you design the community health entrepreneurs to be fundamentally different from traditional health workers? And what is that framework that makes this actually work that everyone misses today?
There are a few things that we have done differently. The community members identifies the women for the training. A woman who has the time, who has some basic education, 8th to 10th grade, and should be able to use a smartphone, so that she can use a smartphone to collect data, to connect to the telehealth app. Our training methodology, which we call it as a 4E model, that is the equip, establish, elevate, and enable. We equip them with knowledge, we equip them with information, with skills to be a change maker in their own homes and in the community. By the third month of training, we start establishing them as a health leader in the community and go to a person. Like, simple example, if a person, community health entrepreneur who has been selected, she doesn't have a toilet in her own house, how is she going to be going to the community and talking to them about building a toilet? So the first step is they have to bring about a change in their own homes. They have to build a toilet. It's just a smallest example. They have to show the behavior change, and that is the one which establishes them in the community as a change leader. After that has happened for the first 6 months, then we elevate them as entrepreneurs. We start giving them health-based products like sanitary napkins and nutrition powders that they can sell to the community and earn an income. I mean, we don't give it for free. They'll have to buy from us because we want them to be self-sustaining. And the last step is we enable them with digital tools, telehealth program, and with system linkages, because we are, after all, an NGO and a non-profit. It has the government systems which is built have to service these communities, and therefore we build the system linkages. During the training, we invite the government people to come and do the training. So a link is created, coalition, kind of a coalition is created, and they are able to facilitate the services that is required by the community.
Your results suggested that you crack something which is more important. You have 94% plus health behavior adoption versus 20% or so useful consultations rate by other platforms. So when people see some semi-literate rural women, they assume limited capacity. What are
Right.
they getting wrong about these women can actually accomplish?
The eSanjeevani was structured so that there could be access, but they did not take into consideration the community's skill sets and what the community can do, because you have to log in and you have to enter all your data. Many of them don't have smartphones, many of them don't have networks, and they're not literate. And then once you have entered all the data, you just have to wait to get an appointment. Then you would have to go to a center, which is invariably the PHC or CHC. And you don't know when you get called in. A poor person cannot afford to lose a day's wages to be able to go and indefinitely wait for an appointment. One, it is not as accessible. It has to be done at the PHC and CHC, and most of the time PHC, CHC are far away. And the second thing is they are not literate enough. They don't have the devices to access. And the third thing is most of the telehealth applications starts with the nurse or an educated person who has access to all these networks. And here we are trying to provide access to the poorest of the poor in the remotest areas. And that is the big difference, because it needs to be voice enabled or it needs to have a device. And that is what our CHE has. And that is why we have been successful. And the other important part of it is that the community, the CHE, when she connects the community member to our telehealth program, there's a telehealth executive, because the community member and the doctor can speak Hindi, but the language is very different. People don't understand. And therefore, we have a telehealth executive who is also part of the community, who understands the jargon, who understands the language and able to translate and simplify the doctor's direction and their advice to the community member, and the CHE will follow up with the community. And if there is a problem that it's an elderly person, they don't have anybody to go and get the medicine, the CHE supports them. If they have been referred to the doctor, then if they are not able to go, she goes and finds out what is the problem, why they have not done. And this follow-up and the continuum of care, that is missing in most of the telehealth interventions. I think that is the biggest differentiator.
So, what's emerging is that the CHEs aren't just delivering the healthcare differently. They're proving that the community embedded solutions can really outperform the centralized digital platforms. Okay, coming up next on how these women become crisis responders who handle emergencies that overwhelm the government systems. So, Mukti, tell me about that June evening in Bihar. Your CHE gets an urgent call from Beria village. Kids are falling ill. What happened next?
Okay. In that particular village, what had happened was suddenly we saw multiple calls coming, and the CHE called our staff and say, I don't know what is happening. There are 6 children who have fallen sick. They've been having diarrhea and they are vomiting. We don't know what to do. And then within about half an hour, there were at least about 10 to 15 calls. Immediately, our staff, telehealth doctor, informed the local staff and said something is going wrong. Can you go there and find out? So immediately he rushed to the CHE's home, and they saw there were about 15 or 18 children who had fallen sick, and they were all fainting. And we activated the government system and informed them, but it was late in the night, around 10 o'clock, and winter, and they couldn't come in. We have a network of hospitals for the telehealth for referrals, and we have negotiated rate cards with them. So we activated the network hospital and rushed these children to the hospital, and we started them on IV drips. And next day, early morning by 7 a.m., the ambulance arrived with the PHC doctors, and then they found out that there was actually a wedding that had happened in that village. There was some food poisoning, and it just affected only the children because they are the ones who are the most vulnerable. And about 3 or 5 children had to stay in the hospital for about 5 days. So these are, these are outlier events, but these keep happening often. We have, like in Buxar, one of our CHEs lives in the on the railway track, very close to the railway station. And one day she was standing at the window and she saw a big crowd. And then her 2 sons came running to her saying, there's something happening. Somebody has fallen off the train and he's injured. The children knew that she has been trained in first aid, Tetra Devi. Rushed there, and it was one of the soldiers who was going back home, and he had fallen off the train, and both his legs were cut off. It was bad. So immediately she went, and she had learned to, she immediately cleared the place, got a bedsheet from her house, got 2 bamboos, made a stretcher, and tied a tourniquet. And quickly, with presence of mind, she went and got the legs and put it on the stretcher and rushed her to the district hospital. And his life was saved because of her presence of mind in doing that. The district magistrate, actually, after that, and the railways gave her a certificate in a function. And these are just small examples of what the CHEs do.
Got it. Let's talk about money. What are CHEs actually making from this health screening, teleconsultations, selling products, helping people? And honestly, is this a real business opportunity, or are these women essentially doing charity work?
Okay, 2 things here. Part of it is charity because I call them the walking, talking wiki because they are only imparting information. You and me, when we want information, we go to Google and get whatever information that we want. We don't pay, there's somebody else who's paying for that through the advertisement. So the women, the preventative health education that they do, they think, when I ask them, why can't you charge money for this? They said, Madam, Gyan, they are giving, imparting only knowledge, and nobody charges for knowledge. And they're only teaching, imparting that information that they have got through a subsidized training. But for the products and services, they charge. And like we call them entrepreneurs because all of them are not successful entrepreneurs. I always say they make anything between 500 to 5,000 rupees, depending on their skill sets, depending on their inherent entrepreneurial spirit. So usually they make anything between 1,000 to 3,000 rupees, which is a big amount. Some of them are outliers. They have made 5,000, 7,000 also. And through the sale of products and to the services. Services is after the second year, we teach them how to do vitals, blood pressure measurements, HB measurements, and blood sugar. For all that, the community pays. We have also taught them, because they are digitally enabled, to collect data. They get paid. And for entitlements like Ayushman Bharat, which is the government's health insurance, or PDS or an Aadhaar card, and through that they earn their income. So it can be anything between 1,000 to 3,000 to 5,000. We have had women who have become widows after they have joined our program. And they have run their houses through the income they earn through the CHE program. It's a complementary program. I don't call it like a true quote-unquote entrepreneurship. It is not as much as a business, but it's a complementary income. And some of them have made it into a independent income as well.
When you are recruiting women to become CHEs, what are your pitch? What's actually in it for them beyond just earning some income? What makes them to say yes to you?
The change in their life. They always tell me, I was somebody's daughter, I was somebody's wife, but today I have an identity of my own. The dignity, the respect, and the acceptance of the community, of their own families and the community. We have done a TIS from Bombay, did a third-party evaluation. And one of the things they brought about is the confidence by coming to our training program. First time ever, they have moved out of their own homes and villages on their own. They didn't need somebody to chaperone them. They didn't need a husband or a mother-in-law or a son to take them elsewhere. They get them. Freedom of movement was one important thing. The other thing is the agency that they could claim by doing the work that they are doing, the acceptance, the recognition, and the respect, and become a decision makers in the family finances. Earlier, even though microfinance, we talk about the women getting the loan, but they usually get a loan for a family business. It is not their own income. It becomes a family income. The income they get from this is their own income. And so these are things that attracts them.
Got it. You keep calling this Phygital, mixing digital tools with in-person care. But 97% of the rural households don't even have decent internet. So how and when a CHE tries to do a teleconsultations or they learn from your platform with a glucometer, how does that actually work? And when the connections is so unreliable?
When we started off, COVID was I think was a defining moment.
Okay.
Defining moment for different things. One is the push into using digital tools. So we did most of our training on Zoom and Eco platform and on Google Meets, and they could. And even today, only 47% of the women own a smartphone. The smartphones are always given to the boys and the men. It's a family phone. So we insist that the women should have access to that phone. And when we call it Phygital, because it's physical, there are trainers and there are field coordinators who are all women who go to the communities, villages, and visit. And these women, a cohort of 50, come to a central location for training. One of the important things from the second or the third month is they have to collect data about 300 households on an app on the phone. And today in India, most of the villages has network, but there are some villages, the networks are not so good, it's patchy. So they have learned. Today, women are very comfortable. In fact, we start off with WhatsApp groups, give us voice messages. start sending your photographs, and they report to us on a daily basis what work they do, because we have connected the digital literacy with empowerment and money earning potential. So if it's a fee for service, so you collect X number of household data, you report and send photographs, get paid. It's what we call our program is a hybrid. Most of them are well versed using a phone by the time they finish for 6 months. Asha workers and Anganwadi workers are not. So they go and support the Asha workers and Anganwadi workers sometimes to just enter the data. And they get recruited as Asha and Anganwadi workers as well.
So critics would say, you have got some semi-literate women providing health services across. Now you have got over 10 states. That sounds like a kind of a liability nightmare. What are CHEs actually allowed to do medically, and how do you make sure that they don't cross the lines?
They go, the first year is all about preventive health education, creating linkages, licensing, how to do health camps, all of that, and using the mobile phone. It's on water and sanitation and nutrition, etc. It's all about preventative education. The second year, they go through a telehealth training, which is a lot more intensive. The first year, it's all on the job training. The second year, there's a lot of theory, there's a lot of examination, and there is a lot of patient care. And this whole program was developed by Stanford Emergency Medicine. And at that point in time, we called it the Basic Care Provider Program. And we worked very closely with Dr. Aisha Khan and the others to make the program relevant to the community and to be able to take into consideration the legalities and the liabilities, as you put it, of the community. So we do not keep any medicines with the CHE. We don't encourage that either. Any prescription has to come from the medical doctor. We have 4 doctors on our payrolls, and they would have to see them, and they will have to give the prescription. And the medicine is also, in one area, we're doing a pilot to see if medicine delivery would help. And through American Heart Association's first aid program, all of the women are trained on that. It is a certified first aid program where there is a written exam, there is a viva, there is a practical, and they are able to do the first aid. They can only, and they identify major illnesses and emergencies through a protocol that is taught to the doctors, the ABCD protocol and LMNOPQ. But we draw a line. We do not allow them to do any intervention. You identify a serious illness, give emergency, and provide first aid and triage them. Triage them to the hospital, call the ambulance services, and send them to the government or the private network of hospitals. And if we hear somebody is doing that, we immediately withdraw, we take away the certificate, we take away the kit, and we inform the Gram Pradhan and the Asha worker that she's doing something unethical. They also sign a bond with us in the sense that an MOU is signed on a bond paper that they are allowed to do only 1, 2, 3, 4, 5 services. We're very clear on that.
So
because the liability is huge.
Sure. Here is what is interesting. So your CHEs aren't just doing health stuff, but they're also advocating for toilets, getting people enrolled into government programs. How did the health entrepreneurship turn these women into community power brokers?
The first 3 to 4 months, and the 4th month is the time when we teach them in first aid. That becomes the inflection point because the scorpion bites, accidents, falls, burns, poisons, they treat it. They treat it. When I say treat it, they give first aid. They provide first aid. Drinking fertilizer and is the most common thing that you would find in the rural agricultural communities. And the first go-to person is the CHE. Immediately she goes and gives salt water extracts, etc., revives them and sends them off to the hospital. Same thing happens to her. So that becomes an inflection. Today we do the telehealth. The training is an ongoing training. The first year, it is 4 days a month. They come to us for training. They go back home with specific home assignments that they have to do. We have almost done about 80,000 consultations. We started the telehealth only after the COVID.
CHEs are basically community infrastructure. They handle crisis, they bridge technology gaps, they build social influence. But that raises a big question about whether this can actually integrate with government system and scale. So coming up next, why your successful model can't just plug in to eSanjeevani, which is India's national teleconsultations platform, and what's really blocking community innovation from scaling. So, Mukti, here is what I don't clearly get it, and that is eSanjeevani currently does about 344 million plus teleconsultations, but 20% are actually useful. But whereas you have got 8,000 plus CHEs, at about 94% behavior change. So why can't you just plug into eSanjeevani? And what's really stopping from doing that or making it happen?
I wish it was as easy as plugging my system and my computer and laptop, but it's not as easy because eSanjeevani program is the government program, and there is a lot of hoops that we have to jump before we can plug in there. And one of the things that we have done with the CHGs is to create access. Each of the CHC PHCs have to conduct camps and they have targets to meet. And now we are working very, very closely at the grassroots level, at the block level, and sometimes even at the district levels to work with the government systems and facilitate the access into the government system. I guess it will happen, but it will take some time because the eSanjeevani has been, like I said, it is a top-down approach. And most of the government programs, whatever innovations that you see, stops at the block level. The ASHA worker is expected to carry the burden of all the government programs at the community level. This is only so much that the ASHA worker can do. And eSanjeevani is also programmed in such a way that you would have to enter the data, you would have to go to a place to be able to get the consultation and connectivity. In some states, you would have to be referred, the patient has to be referred by the PHC doctor to the eSanjeevani portal. And there are people who sit in PHCs with the laptop and the camera according to an appointment and the availability of the doctor would do the teleconsultation on the eSanjeevani platform. It takes a lot of effort and time for a poor person to go through this whole steps. We are hoping that in a few years the government would recognize and would be able to partner, because right now the focus for us is in NCDs, non-communicable diseases of diabetes and hypertension. And these two, again, the government is looking at it more from a treatment perspective. We are looking at it from a continuum of care perspective, from preventative to be able to help them through the treatment and continuous follow-up. And I'm hoping that the government will start recognizing that and we would be able to plug in. It is considered a social good, but it is not a plug and play. We have to be able to do the system change, show that the number of consultations increase and there is actually a change and there is an outcome. We are at present working on an NCD system change program at some of the, I don't want to name the CHCs, PHCs, and we will be working in both in UP as well as in Bihar, and we are integrating our program showcasing. And right now, we are also working with training the ASHA workers and some of these initiatives, because it is just thrust upon them and they get a one-day training. They really are not knowledgeable on that. So we are getting our presence felt and showing that there is a positive outcome through our CHEs, and documenting all of that so that we could work with the government on this. It's a long way to go.
You keep talking about the healthcare data being so fragmented everywhere. They don't talk to each other. Give me a real example. So, when a CHE is helping someone in a village, what information are they capturing that these government platforms never see?
The government does capture information, but it is a one-way track. The ASHA worker at the community levels captures the data. She doesn't know why she's capturing the data. She doesn't get any dashboards. She doesn't know how to use the data. The biggest difference from the ASHA and the CHE is the CHE is aware of what data she's collecting, for what purpose, and we give her the dashboards so that the data and the information is fed back to the CHE so that an intervention is planned. For example, part of the training is that she has to collect certain household data and data, health financing data, and the preference of where she goes, the household goes on the what we call the community registry, and people who have certain illnesses and high risk cases for diabetes and hypertension. The government also captures that high risk data for diabetes and hypertension. The biggest difference is we send a dashboard to the CHE saying these are the people who are at high risk. So you would need to start family counseling, you will need to start follow-ups, you will need to work with the Gram Pradhan to bring about a lifestyle change. That is the biggest difference in the data that we collect and we feed it back, and the government is just a one-way track which goes upwards, nothing comes downwards.
Let's say I'm a social entrepreneur and who wants to replicate your model in Karnataka or West Bengal. What would you tell me are the things that I absolutely cannot mess up? And what kills these community driven models?
Our program is modular. We have done it across 10 states. We have done it across the borders in Indonesia. And but today, of course, we have narrowed it down to the poorest areas like Bihar, UP, and Jharkhand. And that to the, within these three states, also we have chosen the poorest of the states. So our program is modular. And when we started the program, we had men and women. So one of the non-negotiable is it has to be a woman. It has to be a woman from the village, and the woman who has had her last child who is a minimum of 5 years. Why is that? Because when an adolescent girl is trained, she would get married and go to her husband's village or husband's home. And it takes her a few years, minimum of 5 to 7 years, to establish herself in the household and in the village. By then, she has forgotten everything, whatever she has learned. So that is the reason we say it has to be a woman whose last child is at least 5 years old, because the child will start going to the Anganwadi center or the schools, and she would have some free time. And the next important thing is there has to be a basic education so that she would able to assimilate, and we will be able to impart the knowledge and use her mobile phone. And the other thing, important thing is we don't recruit women who are from the poorest of the poor households, for the simple reason she is struggling even for one meal a day. She has to work. So this woman whom we train has to be from the backward castes. Why backward castes? so that she would be able to go to the Dalit bastis, to the lowest of the caste, and impart knowledge and do the training and the interventions. And healthcare is such that even if it is from the higher caste, a person has had an accident, we need to save their lives. So at that time, the gender barriers and the caste barriers break down. So if it is from one of the lower or the backward castes, she is accepted into the higher caste homes for the simple reason she's saving lives and limbs. And and also there has to be an oversight. There has to be a commitment, because we continuously refresh our knowledge, and we have, even though our medical systems don't have the CME, continuous medical education, we keep in touch with the women. We train her periodically even after the training is done. And these are some of the non-negotiables that we have. And we are not asking for anybody with medical knowledge, anybody with health knowledge. We will impart that. She wants to bring about positive changes in her life and in her family lives, and should be part of a self-help group, a trust group, so that she knows how a cohesive group works.
Got it. So another dimension is, the rural health tech is projected to be 11 billion to 20 billion market. But when you look at it, about 80% of that investment goes to the urban solutions, serving about 20% or 28% of the population. What would actually shift investors towards rural models that serve the majority?
The scope and the scale of opportunity and the outcomes, the positive outcomes. If somebody is interested in scale and in the scope of change, then it has to be rural. And the other important thing which most of the investors want is evidence. And that is what our women do. And the third one is, people do love to talk about the business, quote unquote, business models. Where do the business model flourish? That there is some basic infrastructure that exists. So the first 1 year that we are training the women, we are basically building the human resource, the infrastructure, and the linkages. After that, there's a business model. So whoever is coming into the rural areas should come in with a lot of patience, and it has to be a mixed bag. If they are expecting the kind of return on investments that possibly happens in the urban centers, that's not going to happen, because we don't have the infrastructure. There are no blood banks. There are not many pharmacies. There are no qualified providers. So we have to build that infrastructure. So it has to be patient. Somebody who is with philanthropic capital, who has patience to walk the journey. Yes, there is a business model. But and one thing I can very confidently say is, with the scale of opportunity and scope, you feel good at the end of it. You feel good because you've saved lives, you have saved limbs, and you have provided quality health care for people who don't have an access. Many of the technological innovations that you see today is all from educational institutions, from hackathons, from possibly from boardrooms, but not a lived experience, or not taking the people whom we serve to be partners in the innovation.
So I see there is a fundamental tension. Do you really try to fix existing government platforms, or do you enable community alternatives like what you're doing? It's a resource allocation decision, and that affects millions of people. Coming up next, your audacious 2030 vision to reach 300 million people, and what systemic changes would actually make that possible. So, Mukti, from micro insurance to CHE's digital platform, what fundamental assumptions about rural health care should policymakers abandon, and what are they getting completely wrong?
I'm not here to change any systems or fix any system. We are facilitating into the system. We are strengthening the system by seeing what is working and how do we support facilitation. So when people say system change, I'm not doing any system change. I'm only doing the system facilitation because the system is already there. How are we facilitating? Through the evidence of the work that we have done and the evidence. That is what shifts any kind of system or any kind of attitudes to show measurable outcomes and the real cost of saving for the health system and a community ownership. These are the three things. And so when we start showing these three things, evidence of change, the outcomes, and the real cost, real savings to the healthcare system, that is what is going to attract people into the system. And people want to even invest here. And frankly, the second one, of course, is the innovation, frugal innovation, where we are taking the community we serve as our partners. Make it real and relevant to them, not real and relevant to you and me. And when they start feeling the ownership in it, then you will see a lot of change. And the third and the most important thing is we need to reframe the story. Rural people are just not marginal, and the rural models are not outdated. One of the things is we need to look at rural areas not as charity, but with dignity and treat them with the respect that they deserve. Discuss with them, make them our partners, and show the change. Because the little that we do, they take it seriously and they make the change. I'm not teaching them anything. I'm just showing that I'm doing something differently.
But your 2030 vision that you have laid out, it is quite audacious. You're talking about
Very
some
audacious.
300 million people. You're currently 6.25. That is close to about 45, 46x expansion
Yeah.
from where you are now. What systemic changes does this require in how India thinks about the healthcare delivery?
One of the most important system change that needs to come in is rebalancing the system itself. The system needs to be a little bit open to the NGOs and the people who are working in this sector. And as part of that, for rebalancing, there is one ASHA worker. The ASHA worker started her journey and they came up with that for maternal and child health. But today she's expected not only to do the maternal child health and reproductive health, she has to take care of the adolescent girls, she has to take care of the babies, she has to take care of water and sanitation, she's supposed to be doing education of nutrition, she's supposed to be treating. There are about 78 different data sets and 22 different registers that she has to fill in. Where is she going to have the time? So we need to look at rebalancing the whole system. Can just one woman who is a semi-literate without enough training, will she be able to do this? No. So we will need to show the evidence how another person would be able to change the whole balance and change the equation. And the second thing I think I've been harping on that is we need to integrate technology a little bit more intelligently. Like the eSanjeevani program is not accessible to the community because we didn't take them into consideration when we built that, so that they will use it, they will own it. And the third is a lot of financing models need to evolve. They have to evolve. Rural health needs long-term investments, not just pilot funding. Every district hospital has been converted into medical colleges. Where is the money for the infrastructure development? Where are the teachers? So that needs to change. We need to build the rest of the systems before we can say that we have X number of medical colleges and this many aims that are there. We have to relook, review, and then they said that for the rural masses, there is a shortened medical education. Why? Because they are as human as you and me. Their needs are as much as you and me. So we need to be able to strengthen the system to be able to provide cutting edge education, cutting edge technologies, getting them into changing the whole system. And ultimately, any kind of system change is about shifting from a provider driven system to people driven systems. We are still provider driven system. We are still top down. Can we go and be bottom up? Get the communities to own up. And that is what will change. We need to change.
All right. So, what emerges from this conversation is healthcare transformation isn't just about technology. It is not about just funding. It's about challenging fundamental assumptions about how change happens in the rural communities. Is that a fair summary?
Yes. Yes. And build the capacity of the rural masses. That is where we have to go. That's where the 70% of our population lives.
This is the call to action for everyone who's listening. So, Mukti, you laid out 300 million people, the policy barriers, the investment imbalances. But let's get practical. If the healthcare minister was sitting across from you tomorrow, what's the one argument that you would make could actually shift how India thinks about rural healthcare?
Rural healthcare is not a side issue. It is the backbone of our nation's health. We cannot ignore that. Most of the Indians live outside the cities, yet the bulk of the investments goes into the cities. It doesn't, and cities, the infrastructure and the innovation is all urban focused. We are not taking into consideration the reality of the rural masses, of the women, of the children. Strengthen the women leaders. Make them the center of any policy decisions in health. Because world over, the woman is the custodian of health in the homes and in the communities. Take that reality and change. If India wants resilient health system, it has to start with rural India. It cannot start in urban India. Shift the balance.
Looking at your journey from the soul breaking conversation at the Terminer to 8,000 plus CHE reaching over 6.25 million, I think now you close to 9 million plus. What single biggest misconception that leaders still have about rural healthcare transformation?
They all think that the rural poor have to be saved. But in reality, the rural masses, I won't even say the poor, they already have the solutions. They have the resilience. They have the network. And what is it that they lack? Resources, recognition, and systemic support. Give them these three and see the change, exponential change that will happen.
So here is what this conversation reveals. First, the scale without quality is meaningless. eSanjeevani has over 344 million consultations, but with only 20% useful outcomes proves that the biggest doesn't matter all the time. Second is community beats technology when the trust matters. We talked about trust a lot. 24% behavior change rate shows that embedded relationships outperform digital platform every time. Third, the real barrier isn't funding, it is assumption. We keep building urban solutions for rural problems and wonder why they fail. Fourth, the true innovation solves multiple problems at once. CHEs don't just deliver healthcare, they create entrepreneurs, community leaders, and social change simultaneously. That's not just a business model, and that's a system transformation. Have I missed anything else?
Give them the opportunity, give them resources, give them recognition, give them systemic support.
Got it. You know, Mukti, when we discussed Rutger Bergman's moral ambition in our Turn the Page book club in Hyderabad in June, where you are also a fellow member, your work kept coming to my mind. And you lived that philosophy using your skills to tackle urgent problems, not just build a career. That's the real impact. So thank you
Yeah.
for providing that community empowerment and rigorous evidence can actually transform how entire system work. It was a
Thank you.
fascinating conversation. Hit that subscribe because we are the only podcast extracting implementable frameworks from breakthrough innovation like this. Share this episode with someone who's building rural solutions. They need to understand why community embedded models outperform top down platforms. Coming up next on the Spark and the Forge, Eric Kaplan, the Moneyball analyst's legend turned Databricks AI evangelist, on spotting the enterprise AI opportunities everyone else is missing. In the meantime, keep building solutions that amplify communities, not replace them. I'm Subrata Kar. Thanks for listening, and bye for now.